Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. And thank you very much for coming early on a Sunday. And I would like to start by thanking the organizers for inviting me to talk about this important issue, cardiometabolic risk factors in Ramadan in general. And the first session will be from myself and my colleague, Dr. Khadija Hafiz, about diabetes. What we thought we would do, we try to make it as interactive as possible. So we have 4 presentations. So what we thought we would do is speak for about 30 minutes for each of them. So we'll speak about 25 minutes, allow 5 minutes for discussion. And then at the end of the 4 sessions, we can have a general discussion at the end because we want to hear people's views and questions and so on. So to start with, so the first session, we'll talk about the issue of risk assessment and who should fast and who should not fast of those with diabetes. I don't have any conflicts of interest to declare. So this is the outline of what I'm going to talk about in the first session. So general introduction about diabetes and Ramadan. We have guidelines, and so I'll just go through the history of these guidelines over the years and how they have evolved. And we have this organization now, a joint between IDF, the International Diabetes Federation, and DAR. DAR stands for Diabetes and Ramadan Alliance, International Alliance, and they together, they produce guidelines. And they produced a new risk assessment tool exactly to address this issue of who can fast safely and who should not fast. And then I will briefly go through some studies that attempted to validate this new risk tool. So first of all, how common is diabetes? The IDF, the International Diabetes Federation, the latest estimates from 2021 says about 10% across the world. So 10% of people have diabetes. That's the world prevalence. The estimate for the number of Muslims in the world is 1.9 billion, okay? So if you apply that 10% prevalence, roughly, you will have 190 million Muslim people who have diabetes. And it's generally estimated that roughly about 140 million of these people who are Muslims with diabetes are expected to fast in Ramadan. And this is why it's such a big issue, because there are such huge numbers. This is the ayah from Surah Al-Baqarah, which is relevant to the issue of Ramadan fasting and chronic illnesses. So I'll just read the ayah. So, أياما معدودات فمن كان منكم مريضا أو على سفر فعدة من أيام أخر وعلى الذين يطيقونه فدية طعام مسكين فمن تطوع خيرا فهو خير له وأن تصوموا خير لكم إن كنتم تعلمون. So the key word here that addresses the issue of chronic illnesses is وعلى الذين يطيقونه فدية. So the general translation of this ayah is fasting for a fixed number of days. But if any of you is ill or traveling, the prescribed days should be made up later. So this first part deals with temporary or transient illnesses. The second part deals with chronic illnesses. وَعَلَى الَّذِينَ يُطِيقُونَهُ فِدْيَةٌ. And for those who can do it only with hardship, الَّذِينَ يُطِيقُونَهُ فِدْيَةٌ, the redemption for each day is the feeding of a poor person. Okay, so that's the general rule from Quran. Generally, the rule is that the people who are sick are exempt from fasting. But the question we need to address is, should we consider people with diabetes in general, consider them sick, and therefore they are exempt from fasting or not? That's the main question. And if you go to fiqh, the Islamic jurisdiction, this is the general rule. So the rules say exemption from fasting is allowed if, in the opinion of a trusted doctor, fasting is expected to lead to this, either worsening of the disease or delay in its healing. So that's the general rule that we should apply to decide if someone should fast or not. However, we have to remember that fasting really is a very personal decision. And many people, they may recognize the risks of fasting, but they still insist on fasting. And one of the reasons why people insist on fasting is that people with diabetes and many people with other chronic illnesses in general, they don't like to be left out. They don't like to be labeled as sick. And we also have to remember in addition to the religious side of Ramadan, there is also the social side, very important, the social aspects of Ramadan. People during Ramadan, it's a special time. People eat together at the iftar time with family, with friends, neighbors, and so on. And people don't like to be left out because they feel if they don't fast, they'll feel left out of this social aspect of Ramadan. So we need to keep that in mind. So when people with diabetes come to us as health professionals, they have two main questions they ask us. The first question is, what is my degree of risk from fasting? And would you advise me to fast or not? That's the first question. The second question, some people come to us, they have already made up this decision, they're going to fast, whatever we tell them. And they come to us asking for advice on how best to fast safely. So in the first two sessions from me and Dr. Khadija, we're going to address the first question about risk assessment. And then in the second two sessions, we're going to talk about how to advise people to fast safely. So first, the first question about risk assessment. And there are actually guidelines to help us with both these issues. We do have guidelines. However, I think it's fair to say the guidelines are mostly based on consensus of expert opinion, and also some extrapolation from studies done in outside fasting, just in diabetic people in general. We extrapolate the evidence from those and apply it to fasting. However, having said that, in the recent years, we have had quite a lot of evidence emerging from a number of studies. So we have observational studies, and we also have some interventional studies performed during Ramadan, which can actually guide us with helping people assessing risk and helping them advise them to fast safely. And this is a study done by our friend and colleague, Dr. Salim Bishia from Abu Dhabi. And he looked at the number of publications containing diabetes and Ramadan over the years, the 30 years from 1989 up to 2018. And as you can see quite clearly, the number of publications on this issue has gone quite a lot, especially since 2005 onwards. So there is a huge interest in this area. Okay, so one of the earliest studies that looked at the issue of diabetes and Ramadan was this study, published back in 2004. This is an international survey. It's called the EPIDIAR, Epidemiology of Diabetes and Ramadan. It was performed during the Ramadan of 2001, and the results were published in 2004. And they surveyed a total of over 12,000 patients from 13 countries. So it's quite a big survey. And one of the lessons we learned from this study, the first information we learned is that a lot of people with diabetes do fast in Ramadan. We learned that from that early study. So the number of people who fasted at least 15 days of Ramadan, 43% of people with type 1 diabetes and 79% of people with type 2 diabetes. So a lot of people do fast in Ramadan. One of the lessons we also learned from that study is that there is quite a large variation in interpretation of the issue of exemption from fasting between different countries. So the number of people who fasted at least 15 days in type 1 diabetes, 9% of people with type 1 diabetes in Morocco fasted. But when you go to Saudi Arabia, 72% of people with type 1 diabetes fasted, almost 3/4. So you can't say this is right or this is wrong. It's just different interpretation of the rules. Again, the same thing for type 2 diabetes. In Turkey, 58% of people with type 2 diabetes fasted. But when you go to Bangladesh, 90% of people with type 2 diabetes fasted. So there is a huge variation. We have to keep that in mind when we advise people. There is different cultures and so on in the interpretation of the fasting rules. Okay, so we learned from the EPIDIAR study and from other studies about the risks to people with diabetes from fasting. So what are these risks? Well, the EPIDIAR study told us that if you compare people before Ramadan and during Ramadan, looking at severe hypoglycemia, so this is hypoglycemia needing admission or help from a healthcare professional, the number of severe hypoglycemia in type 1 diabetes increased 5-fold in Ramadan compared to before Ramadan. And in type 2 diabetes, although numerically the number of severe hypoglycemia was much less, however, still the risk increased 7.5-fold. So there is more severe hypoglycemia in Ramadan. That's proved in that study. How about severe hyperglycemia? Again, in type 1 diabetes, this increased 3-fold in Ramadan compared to before Ramadan. And in type 2 diabetes, increased 5-fold in Ramadan compared to before Ramadan. So these are the risks that we learned from the EPDR study and some other studies. So hypoglycemia is very common in Ramadan. Dehydration, because people don't take fluids during the daytime, so dehydration is very common. Hyperglycemia is also common. Diabetic ketoacidosis can happen, but uncommon. So these are the main risks we need to keep in mind when we advise people about diabetes and Ramadan. Okay, so as I said, we do have history of guidance on diabetes and Ramadan. The early guidelines that were published were from the American Diabetes Association. They convened together a number of experts in the field, for Muslim doctors, but also some people from the US as well. And they sat together and they came up with the first guidelines based on consensus opinion that was published in 2005. And then the ADA updated these guidelines in 2010. And then after that, an organization called Diabetes and Ramadan Alliance was formed, and they joined forces together with the International Diabetes Federation, the IDF, and they formed the IDF-DAR Alliance and produced the joint guidelines in 2016. And then the same organization updated that guidance in 2021, and that's available online. That's the latest we have now. And I must say here, really, one of the driving forces behind all this work has been my colleague and friend, Dr. Mohamed Hassanin, who works in Dubai Hospital here. He's been part of the first group that produced the first guidelines in 2005 and then 2010, and also he's been the head of the DAR Alliance and has been really working very hard on this. So going back a little bit to the 2016 guidance on diabetes and Ramadan from IDF and DAR. So in that guidance, they use what we call a traffic light system. So we divided people with diabetes into three groups. Category 1, very high risk, and they are told they must not fast because their risk is very high. Category 2, high risk, and they were told they should not fast. They have permission not to fast. And then category 3, with moderate or low risk, and we tell them you may be able to fast because your risk is not high. And I will not go through the detail, but just show some examples of what is included in category 1, the very high risk. So these are people who had any severe hypoglycemia in the 3 months before Ramadan, any DKA in the 3 months before Ramadan, people who have hypoglycemia unawareness, and so on. So this is a very high risk group. The high risk group, category 2, people with type 2 diabetes with poor control, type 1 even with good control, still high risk, pregnant ladies, and so on. So this is the high risk or category 2. And category 3, the moderate to low risk, these are people usually with type 2, either controlled with lifestyle alone or with medications that do not cause hypoglycemia, like metformin, like TZDs, and so on. So that was the guidance in 2016. And after that, some research has been done to see how physicians categorized risk. And this is one of the studies done by my colleague and friend, Dr. Bashar Afandi from Tawam Hospital in Al Ain, to look at the variability among physicians in using the 2016 guideline on risk stratification. So what Dr. Bashar and colleagues did, they created 26 typical case scenarios of people who are considering fasting in Ramadan, and they distributed these case scenarios to 312 physicians who deal with people who are considering fasting in Ramadan. And they wanted to see, the idea was to see how would physicians stratify the risk according to the guideline of 2016. They had a suspicion that the guideline was too rigid and maybe it should be changed. So they wanted to test that with this study. And this is one typical case scenario of these cases. So this is a 17-year-old male. He has type 1 diabetes. He had it for 11 years, and there are no complications. He gets a hypoglycemia about once per month. And his hemoglobin A1C, not bad, 7.4%. He takes basal bolus insulin for his diabetes. He monitors as he's advised. He lives in an area where the fasting hours are less than 16 hours, and he does not perform any physical labor. And the two questions that were posed to these physicians were, number one, what is his risk level? And number two, can he fast in Ramadan or not? And look at the response of these experienced physicians about this case. 52% of them said he has high risk and he must not fast. Okay? 28% said he is moderate risk and he has permission not to fast. 20%, that's 1 in 5 physicians, actually said he's he's fine, he's safe to fast. So as you can see, there is quite a lot of variability between different physicians using the old guideline of 2016. And Dr. Bashar and colleague argued that this variability is really not good. There are some consequences to this variability. It can confuse patients because they go to one doctor and that doctor tells them, your risk is high, don't fast. And then they go to another doctor next door and they say, you're fine, you can fast safely with no problems. This can lead to loss of trust in the advice that's given. It can compromise safety, which is obviously the high priority. And even it could actually lead to risk of liability if you give someone the wrong advice. And they realized that there is quite a lot of factors that have not been taken into account in the old guidelines. So things like age, duration of diabetes, level of control, dieting, comorbidities, and so on. So lots of risk factors that have not been taken into consideration previously and in the previous guidelines. So the IDF-DAR group sat together and came up with new guidelines, which is the one we have now. So basically what they said is investigated the different components of the risk stratification, and what they did was assign the risk score for every risk element. They decided on a number of risk elements, which we'll go through. And this is based on the scoring they gave, based on the available evidence in the literature, but also, if there is no evidence, they use their best clinical judgment to come up with the scores. And this is the new risk scoring tool, okay? So I'll go through it, and Dr. Khadija will go through some examples. When it first came, myself and many of my colleagues felt, oh, this is too complicated, that's too much. But actually, when you start using it, if you do it for 2 or 3 patients, we actually timed it after that. We did a study, we timed it, and it actually takes less than 1 minute. Because once you see a patient in clinic and you know them and you assess them and their diabetes and all the details, it takes less than 1 minute to do it. And you can either do it in a paper form or you can do it electronically. So this is the new risk assessment tool. And going back through to the case scenario I showed earlier, and let us score this patient. So this is a young 17-year-old male with type 1 diabetes. So let us score this patient. So this patient has type 1 diabetes, so he gets 1 score for that. Type 2 gets 0. For the duration of diabetes, we said his diabetes duration is 11 years, so that's above 10, so he gets 1 point for that. He gets 1 hypoglycemia, we said 1 hypoglycemia per month, so that's less than 1 per week, so he gets 1 point for that. And his medication is a basal bolus insulin regime, so he gets 2.5 points for that. So his total risk score is 5.5. And what does that make him? That puts him in the moderate risk group, which is between 3.5 and 6. What does that mean? Well, the moderate risk group, the guidance is these people should be told that the fasting safety is uncertain, and generally they have permission not to fast. However, as we know, in practice, many of these people insist on fasting. And if they do insist on fasting, then we should do a full medical evaluation. We should adjust their medications, and we'll come to that issue later. And we should advise them on strict monitoring of their glucose levels during Ramadan. And I think there are lots of advantages to using this new risk assessment tool. I think the first point is it can create consistency between physicians, and that can only be a good thing in assessing the risk. It will improve confidence when almost all health professionals will tell you the same thing, because they do the same scoring and they come to the same conclusion. So the patients will feel confidence in the advice they are given. And very importantly, the risk assessment process can actually be used as an opportunity for education. For example, if you have someone who is poorly controlled or they don't monitor enough, so you can tell them, okay, because your control is poor, and this is obviously, like say, 2-3 months before Ramadan, if you improve your control, your A1C comes down, then your risk will be lower. And if you are not monitoring, but you start monitoring, then your risk is lower. So it's an opportunity for education of the patients. One of the important issues also is that we should really unify the message given by health professionals and the message given by religious leaders. In the past, I think there has been some disparity between these two messages, and we have to realize that not all people go to their health professionals. Sometimes they go to their local imam and ask for advice on whether they should fast or not. This has been recognized in the new guidelines, and the people who did the new guidelines actually went and sat together with religious leaders and showed them the new way of assessing the guidelines. And I think it's important to tell patients that this new risk assessment tool is not just the opinion of health professionals. This is actually backed by by religious leaders. There is a full fatwa and detailed religious opinion about this, which is available on the website for the Diabetes and Ramadan guidelines. This is from the Mufti of Egypt, fully backing this new risk assessment tool and giving a lot of details about that. So the people who did the IDF-DAR guidelines this is from the publication of the guideline. They say it's primarily based on expert opinion, and the highest level of evidence we can give to this is grade D evidence. So they asked for research to validate this new risk assessment tool. And I think that's important. And in the next few slides, I'll just show you results of a study we did in our center to validate this new risk assessment tool. So we did this at the Imperial College London Diabetes Center in Abu Dhabi and Al Ain. We looked at 647 patients with diabetes who were, this is in Ramadan of 2021, 2 years ago. We looked at people who are considering fasting. So what we did was, we did a pre-Ramadan assessment using the new IDF risk assessment tool, and we scored everybody of these people. And then we spoke to them after Ramadan, either when they came to clinic for follow-up, or if they didn't come to clinic soon, we rang them. So we did a post-Ramadan assessment. So in the pre-Ramadan assessment, using the new risk assessment tool, this is how we scored them. So we found 51% of them had a score of less than 3, that's low risk, who are safe to fast. 28%, we identified them as moderate risk with a score of between 3.5 and 6. And 21% identified them as high risk with a score of more than 6. And then we contacted them, either saw them in clinic or contacted them by phone after Ramadan. And we asked them these questions. We did a survey. How many days have you fasted? Did you break your fast due to diabetes-related reason like hypoglycemia, hyperglycemia, and so on? Hypoglycemia defined as either clear symptoms of hypoglycemia or documented less than 70 milligram per deciliter. Hyperglycemia, we defined it as more than 250. And this is the results of our study. So overall, 87% of these people reported actually they fasted the full 30 days of Ramadan. But when you look at the breakdown of this, you can see clearly there is a trend with the increasing risk. So the low risk group, 95% fasted the whole month. The moderate risk group, 80%. The high risk group, 76%. So the higher the risk scoring, the less likely they are able to fast the whole month. How about complications during Ramadan? So hypoglycemia, again, there is a clear trend. So the high risk group had higher risk of hypoglycemia compared to the moderate and the low risk group. How about severe hypoglycemia, defined as an episode of hypoglycemia needing help from somebody else to recover from the hypoglycemia? And this was not common, but again, there is a trend with the higher risk group. So high risk group, 2.2%, and none in the low risk group. How about hyperglycemia, defined as any episode where the documented self-monitoring blood glucose was more than 250. Again, a clear trend. The high risk group had higher risk of hyperglycemia compared to the moderate and low risk groups. So the more severe risks were not common. So severe hypoglycemia was overall in the study only 0.9%, and no cases of diabetic ketoacidosis. And remember, we had 53 patients with type 1 diabetes, and none of them had DKA. What we learned from this study is that the high risk group with a score of more than 6 actually were less likely to fast the whole month compared to the other two groups, and they are more likely to have complications, either hypoglycemia or hyperglycemia. So the overall conclusion from this study is that the new risk assessment tool is actually does predict both, number one, the probability of fasting the whole month, and number two, the likelihood of getting risk from fasting, like hypoglycemia and hyperglycemia. So that's our study. our study was not the only one that attempted to validate the new risk tool. There are now a number of studies. There are now actually 5 studies, including ours, from different parts. So more or less, all of these studies came to the same conclusion. Yes, the new risk assessment tool is very helpful, and it does predict the risk of the likelihood of fasting the whole month, and also the risks from fasting, hypoglycemia or hyperglycemia. So to summarize, I think over the years, the risk guidelines have evolved, and they are much more objective now. We have a much better and objective method of assessing risk compared to the previous guidelines. So this new IDF-DAR risk assessment tool, I think our study and other studies have shown that it has the ability to predict the risk of the ability to fast, and also the risk of complications. However, it's still based on low-level evidence, and there's certainly need for more research to look into this more. So I can take some questions before we go to Dr. Khadija, who is going to give you cases, practical cases of assessing the risk.